But really quickly, before we get started and I hand it to my colleague, Dr. Craig Pollack, I wanted to just quickly, or not quickly, but just position us a little bit and read a land acknowledgement. So at all public events and meetings, we should reflect and publicly acknowledge the original stewards of the land we're on. This is a meaningful way to honor Indigenous peoples and resist erasures of their histories. The power of an acknowledgement lies in learning as much as you can about local treaties, many of which were agreed to under duress and violence, in addition to learning about tribal practices while also working to build accountable relationships with the tribal peoples in our communities. For those of us in Seattle, I recognize that we are on the traditional land of the Duwamish people and honor with gratitude the land itself and the Duwamish tribe. You can find out more about where you live and the land that you're on by visiting native-land.ca. And also please consider how you can actively support tribal sovereignty. Here in Seattle, you have the option of paying rent to the Duwamish tribe. You just can search for Real Rent Duwamish. I also just want to take a moment to acknowledge that the country that we reside in, the United States, was built on the enslavement of Black people. And we continue to see this and other historical injustices persist within our systems. And I hope that you all join me in recommitting to scrutinizing your organization's practices and policies with an anti-racist lens. So I think this meeting is really timely, and to reflect what we heard in the opening plenary, I think as systems, we have an enormous responsibility and opportunity to improve outcomes, interrupt intergenerational cycles of poverty, and health is really central and critical to that. I had an opportunity to actually connect with Dr. Craig Pollack during a Housing is convening this year or a couple years ago, and some of the work that we're doing is actually born out of the connection of this forum. So I'm really hopeful of those kind of connections that are happening virtually to come out of this convening. So with that, I will turn it to Craig to start us out. Thanks.
Great. Good afternoon and good morning, everyone. Katie, thank you for taking that introduction and centering us. I think that was incredibly important as a reminder and as a message. Can you move to the next slide? Great. Again, my name is Craig Pollack. I'm an associate professor of health policy and management at Johns Hopkins School of Public Health. And currently I work a day a week at the U.S. Department of Housing and Urban Development in policy development and research, helping think about issues around the connection between housing and health. This work that I'm going to present here is separate from my work at HUD and does not necessarily reflect the work of HUD. Okay, next 2 slides.
Sorry, I clicked on your email and not on your actual slide. Move us along, sorry. You're seeing my screen and let me find that again. There we go, sorry about that. So
I like starting with this quote from Florence Nightingale, which says the connection between health and the dwelling of the population is one of the most important that exists. So I feel like a lot of people have kind of come to appreciate the social determinants of health only recently, really talking about kind of health and the social factors that influence, but this has also been recognized for an incredibly long period of time, as this quote and as Florence Nightingale shows. And I think we're coming back to this understanding that where people live, work, and kind of move through space has really important ramifications for their health and well-being. Next slide. And I like this framework for people that may be unfamiliar with it about that Lauren Taylor published in Health Affairs maybe last year, that shows kind of the different pillars about the ways that housing and health are connected to one another. And she goes through 4. The first is around the stability of of your relationship to the house, so not being evicted, and kind of other factors. The quality and safety of housing, which is typically where public health has resided, talking about lead and air and other exposures. The affordability of the house, recognizing that there's not enough affordable housing for people that need it. And then thinking about the neighborhood context. And all four of these, individually and in relationship with each other, can have really important implications for health outcomes, healthcare costs, and individual and family well-being. Next slide, please. And so kind of with that as a background, we've been trying to, with my colleagues, to work on trying to understand and kind of build the evidence base for this important and longstanding connection between housing and health. And the first way that we've done that was building on the Moving to Opportunity for Fair Housing Demonstration Program. I'm going to talk really briefly about Moving to Opportunity and the work we've done before pivoting to talk a little bit about the work we've been doing with the Seattle and King County Housing Authorities and the public health group there. So Moving to Opportunity, as many of the people on the call probably know, has really been a touchstone because it's a randomized controlled trial in which people living in public housing in high poverty neighborhoods were randomized into 3 different groups. That included a control group, a traditional Section 8 voucher at the time, as well as a Section 8 voucher that can only be used in a low poverty neighborhood. This was done in the mid-1990s and followed for an incredibly long period of time. Next slide. And so what we did was we linked these individuals, the adults and children in these households, into with Medicaid and hospital data on whether or not they've been using healthcare, whether they were enrolled in Medicaid. And what we did was we were able to take when they were randomized and follow them for up to 21 years after randomization. This figure is one of the main findings from the study that was published in JAMA just a few months ago. What we have along the left side is the rate per 100 person year. So how often are kids at the time of randomization being admitted to the hospital, and along the bottom is for the length of time after randomization. And what you can see here is that the kids in the control arm of the study tended to be hospitalized at a higher rate over time compared to those that were in the voucher groups. Here we combine the voucher groups because their experience of neighborhood poverty, despite the experimental design, ended up being quite similar. Next slide. And so working with Seattle and King counties, we were really interested in what is the impact of having a voucher on healthcare use among adults and children compared to those on the wait list. Moving to Opportunity was great, but everybody in Moving to Opportunity had housing assistance. There wasn't a group that didn't have housing assistance. And so really we're trying to build the evidence base to say, like, what is the added value of a voucher for people that don't have any housing assistance to begin with? Next slide. And this is going to get kind of nerdy, but that's okay. And so the really cool thing about having a waitlist control group is that you can really isolate what is the influence of a voucher itself versus not having a voucher, controlling for everything else that may influence healthcare use. The real problem is that people that get vouchers may be fundamentally different for people that don't ever sign up for vouchers. And so having a wait list allows you to do this kind of estimation, that allows you to get really good, strong estimates that we think can be important when thinking about what is the added benefit of a voucher, what is the kind of rationale and reason, addition to the kind of moral and other rationales for trying to increase the supply of vouchers, or thinking about how those are being deployed in order to improve health. Glad to talk about this in question and answer, but recognize time is short. So in terms of thinking about these relationships and the partnership with Seattle and King County, which really did start after a housing is summit and a kind of a chance encounter, I think there are several kind of key points for me. The first is that these relationships take time to develop. I think there's a lot of trust that needs to develop in terms of kind of what the researchers are interested in, what the kind of housers are interested in, what the different kind of people involved in health are interested in, and coming together and coming to a common understanding. So it is really a partnership, takes time and effort. And I think that it always takes longer than I think it's going to, and like, that's okay. I think that's part of the process. Relationships are great. The data agreements take even longer. So just to give you a sense for the project that we're currently working on, looking at the difference between healthcare use among adults and kids with vouchers versus those on the control, we've gone through the Johns Hopkins Institutional Review Board, making sure that the science is okay, meets the different ethical considerations. So Washington State has their own separate IRB on their own separate timeline. We've also gone through data use agreements with the Washington Healthcare Authority, the King County Housing Authority, the Seattle Housing Authority, and the Public Health Seattle and King County, which is the health department. All of these have required substantial negotiation, and that's not even including the kind of a lot of the existing data agreements that were in place that allows King County Housing Authority, for example, to share data with public health. of Seattle and King County. So that these kind of data sharing are never simple, and I think we would do ourselves a disservice to underestimate kind of the amount of time that it takes. But again, I think it's worth it. And then I think the other really important thing that Seattle and King County have done is they've kind of incorporated language around research into their waitlist consent as people get sign up for the waitlist, so that this data can be used more easily. Again, making sure that the safeguards are in place to protect individual confidentiality. But we think that this is a really important platform and took a lot of foresight in order to create this infrastructure, which we are really hopeful is going to be able to help answer important questions over time. So this is my email address. Please feel free to, in addition to questions during this, feel free to reach out with any questions or comments.
Just take a quick moment to note for all the speakers, there are speaker profiles in the app and agenda. You can also reach out to people with their email addresses on those profiles or on their attendee profiles that are on the app as well.
Great. Going to kick it over to Alistair.
Good afternoon, everyone. I think it's afternoon for everyone now, except for anyone in Hawaii who's joining us. I'm Alistair Matheson. I am an epidemiologist at Public Health Seattle and King County, the Public Health Department, as Craig mentioned, and we have been working closely with both the Seattle and King County Housing Authorities for several years now and have built a great relationship. I'm going to talk a little bit about the data linkage platform that Craig was alluding to when he was talking about the research work that his group's hoping to undertake. And so I presented a little bit on this a couple of years ago at Housing Is. So I'm not going to spend a lot of time digging into that again. I'm just going to recap that briefly, and then I'm going to talk about some of the new developments since then and how that all links in with some of the work that Craig and Katie and others are going to talk about. So that's pretty much what I said. So we'll just skip on. So this is how things were a couple of years ago. This is sort of a one-slide summary of the linkage that we have talked about previously. Essentially what we did is take housing authority data from KCHA and SHA. It was their 50058 data that is reported to HUD, and took that essentially from their administrative data sets, brought that in, did a bunch of sort of cleanup and linkage between those two systems, and then we brought in the Medicaid claims data from our state Medicaid agency, which is the healthcare authority. And so with those three really data sets, we were able to create a longitudinal record of people who were in one or both or all three systems. So we could track people over time, essentially, see when they went in and out of housing, see when they went on and off of Medicaid, and then most importantly, look at some of the health outcomes of folks who were in, supported by housing authorities, and compare them to people who were not, who were just general Medicaid users. So we're able to build up a picture of the health needs and the health profile of folks in the housing authorities. So next. And so when we're thinking about how to communicate that data, we built a dashboard in Tableau. It's fairly flexible. It's publicly available. The URL is there. Hopefully it's all working. And one of the SHA colleagues was telling me it wasn't working, so hopefully it's up and running. But essentially, you can dive into this and explore that data that we have linked. The original plan was for us to share a de-identified data set back to the housing authorities and for them to take that and work with it. We soon realized that that wasn't really an ideal approach for a couple of reasons. One is it's virtually impossible to create a truly de-identified data set when you're working with housing data, because location is an identifier, of course, and that is something that the housing authorities are very interested in naturally. So it's really quite hard to create such a data set. And then the other reason was, I mean, you know, our housing authority partners are fantastic. They have ingested a huge amount of knowledge and information about the nuances of Medicaid claims data, but that's not the sort of thing that they spend their day-to-day activities thinking about, unlike us here in the health department. So it kind of made sense for us to build shared understanding collectively and present data in a way that made sense to them. And so this was the solution we landed on. So that's just one screenshot, but there are many others. So then we said, okay, well, this is great, but we really want to keep building on this. And the next obvious thing to do was to add in the Medicare data. And here's why we wanted to do that. So this is a snapshot from the dashboard again. but it shows where people fit in different groups in the different colors there. So we have a few folks of all age groups, genders, and race ethnicities who we only see in the housing data. We don't ever see them in the Medicaid data. And that's fine. That means they either have other health insurance, they're uninsured, or they have something like Medicare by themselves. Then the key part is this yellow bar where people are both in Medicaid and Medicare. And we're really interested in those folks. They tend to be a little bit different from people who are just on Medicaid. They tend to have quite high health needs. And obviously you can see in the older age groups, which is an area of focus for housing departments, they make up a large majority of that population. And we couldn't really look at those folks without the Medicare data, because Medicaid is the payer of last resort. Or typically health encounters were paid for by Medicare, and we couldn't see that information. So we were missing a lot of information about those people. So we really wanted to fill in that gap. So next slide. And so we were able to do that. Once we've added in the Medicare data, we've now added a new color, which was folks who were just in Medicare. And then we've got now the people who are in dual eligibles, both Medicaid and Medicare. So for those older age groups, we now have almost complete information about their healthcare encounters and their health needs. So this has been great, and we're still really getting our heads into this and digging around a little bit. There's topics of interest that we had started looking at before COVID came along, and we all had to switch attention. Things like, say, falls in older folks. That was an area I had started looking at, and I hope to finish off sometime when I can get back to this in more depth. But this is great, I think, for us and for the housing authorities who have older adults as a focus population. So next slide. And again, this is just to reiterate why we care about these people in particular, apart from the fact that all life is important, and we think everyone would like to look at the health needs for everyone. But particularly the older age groups really drive healthcare use and therefore healthcare costs. And so this is just one slide looking at people with any type of cardiovascular disease from the Medicaid and Medicare data. And you can see the stark increase with age. That's not surprising, everyone knows that. But we can also look at the differences between the people who are supported by housing and those who are just in the general Medicaid, Medicare population, and see those big differences between those groups and think, okay, we see these differences. Now we can think about what we might want to do to address some of those disparities that we see. So next. And just one more slide on future plans we have. This is sort of a long-standing piece of work for us in King County. We are working on this generalized data integration piece. We call it an integrated data hub. And these are just some of the data sets we are hoping to ingest into the data hub and generate a common identity across all of those sets, so we can really get a full picture of social and health needs that people in King County might have. So on the left, you see 4 data sets that we've already combined, particularly the behavioral health, the homeless homeless database, essentially, the Medicaid, and we've just added healthcare for the homeless as well, which is another sort of health provider data set. The ones on the right are ones we have talked about adding in at some point and hope to do in the future, but this is quite an involved process to do that data linkage and combine these data sets, as you can imagine. And say, for example, of housing, I mean, our current DSA doesn't allow this right now. And so we'd have to reformat that DSA and bring on the housing authority folks as real partners on this when it comes to data stewardship, recognizing that we're not the owners of a lot of this data. And so we need to involve the people who are the owners and the stewards and make sure we're all on the same page and have common understanding of how we want to use the data for basically improving the health and well-being of everyone. So that's just a sort of where we hope to go in the future. Really what we have, I think, is a great platform for all sorts of endeavors. There's the research angle that Craig has talked about, leveraging that to compare waitlist data with the folks who are already receiving vouchers. We've got the general sort of needs assessment from the dashboard. And I think we see this as really a great platform. This is not the end. This is just a platform to build on to generate action and improve outcomes. So thanks, and I'll turn it over to the next speaker.
That is me. Hey everyone, I'm Katie Escudero. I am the Moving to Work and Health Policy Manager at King County Housing Authority. I am going to represent both KCHA and the Seattle Housing Authority in my presentation today as much as possible. So a little bit about why we're getting involved in health. You know, I mean, we're all here, so I feel like I'm talking to everybody who already ascribes to this, but I think we really believe that housing is a platform to improve the long-term life outcomes of the people we serve, and we have a tremendous and profound responsibility and opportunity to do that. We serve collectively over 67,000 individuals and 30,000 households in the Puget Sound region. With our moving to work regulatory flexibility, we've really transformed into social impact agencies that try to work across sectors to interrupt and prevent intergenerational cycles of poverty. And I think health is kind of central to achieving that aim. So we know that access to stable and affordable housing is critical to this puzzle, but it's not enough on its own. And health disparities still exist and are rampant in our population. So we have this opportunity and evidence that you know, these health disparities exist via the dashboard and the work we're doing with Dr. Pollack as well. So we wanted to set out to implement health strategies. So today I'll cover 3 things in my presentation: how we're using the data that you've heard about just now from Alistair, our approach to health initiatives, and then I'll spotlight a couple of initiatives that we have ongoing as well. Gotta click the mouse to advance the slide. Let's see. There we go. Okay, so how are we making use of this data? Up to now, we've used it to gain just a solid baseline understanding of our resident population. As you know, these are really disparate systems that people interact with, and we've made our systems incredibly complex to navigate. And of course, that means on our end is people making policy and planning. We were just seeing one piece of the picture, and this really provided us just a baseline understanding of those health disparities that are pretty striking in our population. You know, we saw that our residents are utilizing services related to chronic conditions at 2 to 3 times higher than the general Medicaid population. So I think that was just confirmation that our work in this space is critical, and that we should be involved more than just as a landlord. So as Alistair spoke to earlier, we're working to roll in other data sets to get a better understanding of how residents are interacting with other service systems. A next step, and I think a really critical missing piece that I want to highlight, is that we need to do the work of incorporating resident voice into this work and really ground truth some of these broad population level statistics that we're looking at. I think we want to seek to really understand what the barriers are, but also aspirations related to people's personal health. And so that's work that we've been actively seeking funding for and want to use to enrich, and I think actually like move forward in an intentional and meaningful way with this work. And then just more recently, we've been using it to target programming and planning efforts and opportunities with different partnerships. So I will get into those a little bit more. I want to just acknowledge, we might be neglecting the Q&A right now. For those who've come in a little bit later to this room, we have a lot of presenters, and so we want to get through all the presentations and then have Q&A and discussion at the end of this. So thanks for bearing with us there. So really, we're not looking to become healthcare providers. Our goal is to be a good partner, seek out opportunities to try out innovative approaches to interrupting these disparities that we're seeing. So our health strategy is really focused on 3 things. We're wanting to connect residents to the healthcare system and healthcare resources. We want to leverage and enhance existing resources as opposed to duplicating efforts. And the third piece is we want to work with health partners to design, and implement, and scale novel approaches that better deliver services and resources, you know, where people live, which is our housing. So I will highlight just 2 of these spheres today and a couple of examples of partnerships that we've recently implemented. Let's see. Okay, so the first is Housing Outreach Partners. This is, I'll refer to it as HOP, because of course we love acronyms and like cool names like that. So we are partnering with King County's Department of Community and Human Services and a local behavioral health provider, Sound Health. And we're piloting a behavioral health co-location pilot at our targeted public housing sites. So our sites that house seniors and people with disabilities. The way that it works, just high level, is our resident service coordinators at KCHA and at SHA. they have provider partners in buildings. They're referring residents to the HOP team. And these teams are made up of a mental health counselor and a peer support specialist as well, if people have indicated interest and consented to services in this way. And then we also, across both housing authorities, have access to a dedicated nurse practitioner, and then also a substance use disorder professional to come in and provide more specialized support if needed. So Sound then does the individual assessment, engagement of services, and that could look like anything like ongoing care, consultation, short-term support. It really depends on the individual's needs. And at that point, the housing authorities are really not involved. Our role is just like, I think, connecting as we would in a service coordination way, but it's just more, it's a closer connection because those folks are in community and at our properties. So they're kind of building informal relationships with residents as well. So that's kind of how the model works. And then they're also available to provide limited acute non-crisis response and consultation to our staff if a situation arises. And I will say, I set out with this presentation in December when the proposals were due, but since COVID hit, they've really transitioned to a telehealth model. We implemented this program in February, and so as a new program, we had to really quickly pivot to a whole new way of delivering services in a way that is really not to fidelity of what we set out to do, which is, you know, building those informal relationships and partnerships and having this this presence at our sites. But we had to kind of change course and be really creative about an outreach. So they've been really helpful in crisis response. As we know as housers, is that we're seeing, you know, more issues of isolation, anxiety, and stress related to being at home and related to COVID as well. And so they've been really helpful in being stewards and sort of translators for the crisis response system locally and really advocating on behalf of our residents as well. Unfortunately, this is a sales tax funded program. And with the just incredible economic hit that we've seen in our communities, this program has been defunded, we learned a week ago. So the housing authorities are working together to try to figure out, that was my personal timer. Okay, one more minute because I want to cover one more thing. So we're working really, really closely together to figure out how to keep this service going. There's a state report that says that the symptoms around behavioral health will see an increase in the next 6 months. And so we're just preparing for that increase in need in our communities and are working really hard to keep this service available. So TBD on that. And then just really quickly, I won't go into this too much because my colleagues from Vancouver and Yakima are going to talk about this as well, but we're leveraging the supportive housing Medicaid benefit that's available through Washington's Medicaid transformation. It's called Foundational Community Supports. This, at KCHA, we're using it to target our folks coming in through the mainstream voucher program to provide housing search and stability services, and SHA, they're using this to target folks in their public housing around housing stability. So this is really a way to, I think, frankly, like put the onus back on the healthcare system to shoulder some of the costs. It's a Medicaid billable service. For a long time, housing providers have, you know, been paying for supportive housing services because we recognize how critical that is to ensuring stability for the communities we serve. A lot of these services, you know, are not funded by the traditional federal housing programs. And so this is a way to sort of flip that. And the healthcare system is, you know, this is a billable service. They're covering some of the cost of, and then there's that really huge connection between housing and health. And, you know, if people are able to stay, access housing or remain stable in housing, that has a tremendous impact on health. And of course, we think about sometimes the bottom line in this work, so the healthcare system as well, and the costs are worth it. So I will stop there because I think you'll hear a bit more about the FCS program from my colleagues. Thanks. And there's my info, and then my colleague Andy Chan at Seattle Housing Authority, his info is there as well. As Steve mentioned, these slides are available on the app, so feel free to reach out to us with any questions. Okay, great. Andy, I'll hand it to you.
Thanks, Katie. And so now we're going to travel a few hours south in Washington State to the Vancouver, Washington area, which is borders Portland, Oregon, if you're not familiar. And so far, we've been talking a lot about sort of the broad intersection and important intersection of housing and health. And now, as we transition to this Housing and Health Innovation Partnership that I'm going to talk about, we're going to narrow in sort of a little bit more on a partnership that's really designed around people with the most complex behavioral and physical health challenges. So think about maybe people who have experienced chronic homelessness, or people who have long-term stays in psychiatric institutions. And the Housing and Health Innovation Partnership, or HIP as we call it for short, which makes me the director of HIP, which I'm sure you could already tell from my fashionable headset that I'm wearing today. HIP was, I'm glad somebody laughed who wasn't on mute, thank you. HIP is about 1.5 years old now, and it really formed in the community because different sectors all were seeing the same issue developing from different perspectives. And that issue was that people who suffered from serious and persistent mental illness, paranoid schizophrenia, bipolar disorder, other illnesses, maybe combined with substance use disorders, combined with chronic disease, we're not getting the long-term housing stability that they really need to address some of those health conditions. And what was happening were people were cycling in and out of jails and emergency departments and psychiatric institutions. From the housing side, attempts to serve the population there's a feeling that the support services necessary for success weren't in place. And then from the other sides, it seemed like the housing wasn't there. So this HIP partnership was formed with sort of two goals. One, to just increase the amount of housing options for this specific population. And second, to really make sure that those housing options had integrated social services, healthcare services, all the supports necessary for it to be successful. Next slide, please. So just to spend a little bit more time on sort of the details of what we were seeing locally that we wanted to address, anybody who's done, for example, tax credit development understands how complicated, how many regulations, all those funding sources come with, how much time and energy it takes to put a project together. Medicaid and that whole world that we've been hearing about today, just as complicated. The homeless service system has its own language, its own complications, and long-term care. And what we were seeing was that it just wasn't realistic to expect a single nonprofit that might only have expertise in one of these areas to kind of navigate all these different systems and pull the partnerships together to really create these integrated programs that we knew we needed. Another thing that we were seeing, especially in sort of the housing first supportive housing that we did have in the community, was that there was a gap around engagement services for those with sort of the highest needs, because traditionally, Medicaid only really pays for services if somebody wants those services. So if you're trying to engage somebody to convince them that they need to think about using less substances or tackle a mental health issue, you're only going to be able to bill health care insurance for a very small amount of time unless the person you're working with engages and goes through assessments and so on. So that work tends to fall to the sort of housing case managers or other social services who, if somebody has very complex challenges, it might not have the clinical skill level necessary to be successful. You go to the next one. Thank you. So, so this partnership was formed to sort of add capacity in these areas to the community with the idea that with some limited staffing, which is mostly just one position, and with some pooled funding, we could tackle a few things. We could take some of the brain damage off of our very busy nonprofit partners who otherwise would have to go around and sort of create these partnerships and maneuver in these complex systems. And that we could also provide some funding to overcome what usually, whenever you're starting new work, you're going to have startup costs that you can't always recoup. And then work on the policy and system barriers that are there to try to make sure that these new programs we're working on are sustainable. You know, one example, there was a report that was released in our community that one of the partners that is a partner of HIP published around different kinds of housing options for this population. And nonprofits would then go to try to fill a gap. So the community has identified a gap, the nonprofit would try to step forward to fill it, and they'd still have to sort of prove the case and prove the model and convince different funders that it was a good idea. And we thought maybe if there was a neutral party sort of doing that on behalf of others, it might ease some of that work. Go to the next slide. So I want to just quickly touch on first how we're expanding sort of the supportive housing options and other housing options, and then I'll touch a little bit on more of the integration service side. One thing that, you know, Katie mentioned the foundational community support Medicaid benefit. So this is a relatively new thing in Washington State. It was part of a 1115 Medicaid waiver that the state did. And it's a targeted benefit for people who meet certain criteria. There's an employment side to it that you'll hear about a little later on. And then I'm going to talk about the supportive housing side. You know, so but the key to it was that it paid from Medicaid for support services, which is fantastic, but can't be used for any sort of rental assistance or for the direct housing. So we created a program in partnership with the Housing Authority, some of Section 8 vouchers, a local behavioral health provider providing the supportive housing benefit and billing Medicaid, and provided startup funds to the nonprofit so they could really ramp up their hiring until they could figure out the billing and make it a sustainable program. And at the same time, we're helping different affordable housing developers, including the Housing Authority, where I work, but also other community partners, create different models of supportive housing. One new built environment we're looking at is doing garden style apartments so that people have more control over when they interact with their neighbors rather than sort of a centralized hallway, one entry type building. Another is that the Housing Authority is creating an assisted living facility, especially for people with behavioral health challenges who are coming out of homelessness. Next slide, please. And then on the service side, one of the things that has been pretty successful early on, we noticed a gap in our supportive housing developments that were up and running around personal care services. So just assistance with daily activities of living like personal hygiene, cooking, cleaning, those type of activities. And there were some barriers between that sector and sort of the population we were serving. And so we convened people to kind of talk about how we could bridge that, and we provided some funding and started a pilot program where we have on-site personal care services staff that builds relationships with tenants in supportive housing and provides those type of services, and then takes them through the assessment if they're eligible with Medicaid so that they could have those things ongoing. So that's been really successful, and we've been expanding that work. And another, we've also been building relationships with on the physical health side and behavioral health in general. But I also wanted to touch on, in our setup, in our community, we don't tend to have nonprofits that do everything from A to Z, like the property management and the behavioral health and the case management. Instead, we have multiple partners working in a single program, in a single building. So a lot of the work we've been doing is convening the property management provider, the support services, having weekly meetings, working on what exactly, making sure everybody's on the same page about what the model is, how the communication is going to flow, and just seeing if we can sort of create a team approach, which has been great.
Hey, Andy, like a 1 minute warning so we can move on. Yeah, thanks.
And then this lastly, I want to touch on these harm reduction funds that basically just pay for out of the box type thinking. One quick example, somebody was running their water all night, and we found out that it was because it helped them sleep, so we bought them a noise machine instead. So if we could go to the next slide. And then just to finish, this is what we're sort of working towards, which is, whether it's recovery housing or supportive housing or more crisis type response, can we create a network so that it's sort of seamless from the perspective of the person, so that we don't have this cycle that we're trying to interrupt. So I will leave it at that. Thank you.
Thanks so much, Andy. I'm gonna hand it over. Oh, there's his info. If you want to take a quick screenshot, to Carlos in Yakima.
Yes. Hello, everyone. My name is Carlos Reyes, and I'm the Family Self-Sufficiency Supervisor at the Yakima Housing Authority. So now we're in Eastern Washington. I will be discussing our recent work within the Supportive Employment Program, which is under the Washington State Foundational Community Supports. Like Andy mentioned, Foundational Community Supports, FCS, are targeted Medicaid benefits that help eligible clients with complex health needs reach stability in their health, housing, and employment. And there is two programs, which is supportive housing and supportive employment. Supportive employment aligns employment services and local resources to provide individualized person-centered supports to clients. Income for the program is generated through reimbursement of services rendered. The income generated is based on service rates, which are sufficient to maintain the sustainability of the program. The revenue stream is outside of the typical funding received by a traditional housing authority. FCS, Supportive Employment Services, provides a purpose and structure for individuals experiencing behavioral health challenges, which with the right supports, individuals can reach employment stability. The supportive employment model uses the individualized placement and supports, IPS, best practice to match individuals to competitive employment opportunities in the community by matching individual skills and talents. IPS supportive employment helps people living with behavioral health conditions work at regular jobs of their choosing. Most importantly, this program helps to promote employment wellness, physical well-being. IPS has 8 core principles, which are accomplished through specific activities, such as negotiation with employers, ongoing follow-along supports, and zero exclusion. Everyone who wants to work receives supportive employment services, regardless of any history of illness or substance abuse. Attention to interests. Clients supported to work in fields that are of their interest to them. The IPS provides specific metrics known as fidelity scale to help agencies determine the program's overall performance. Public housing authorities, like any other social service provider, has the desire to do more and help families meet their essential needs. Our community has unmet health needs, which can lead to loss of employment and an increase in homelessness. The Yakima Housing Authority has sought to address the growing service gap through supportive employment. Our goal was to align supportive employment services in combination with our family self-sufficiency program to improve employment outcomes. The Family Self-Sufficiency FSS program is a HUD-funded program that enables HUD-assisted families to increase their skill levels, education, employment to become self-supported. Family self-sufficiency participants needed direct service providers that offered more intensive one-on-one services to clients with additional health needs. Supportive employment provided the much needed capacity and time to be able to serve the clients. The services are integrated to enhance service quality, provide seamless service delivery, and amplify available resources to better serve our community. One of the major improvements from these services has been job retention for our clients. In an effort to continue to address health needs, our next step will be to incorporate a supportive housing program under FCS. The process to become supportive employment provider started with the Washington Healthcare Authority. YHA applied for a grant from the Healthcare Authority, which facilitated our application process. The Healthcare Authority has been a vital component to providing ongoing technical assistance to help us to better understand our role as a provider. In collaboration with the Technical Assistance Collaborative, the Healthcare Authority, we have been working to develop program documents and templates to aid new providers. Recently, the Healthcare Authority has made available telehealth supports to assist agencies maintaining contact with clients and facilitate the continuation of services during the COVID pandemic. The employment focus has shifted temporarily to provide information and much needed resources to our client. Next slide, please. The process to contract as a supportive employment provider led us to AmeriGroup. AmeriGroup is the administrating agency for the foundational community supports. As a non-medical provider, there were a couple of challenges in obtaining the required status to contract with AmeriGroup. YJ had to apply for a national provider identification and a Medicaid ID. The process provided a learning opportunity for the Healthcare Authority to better understand the process for a public housing authority. Agency ownership and the credentialing process didn't accommodate for the structure of a PHA. It took some creative workarounds to enable us to complete the application. Next slide, please. The diagram shown emphasizes the low barriers approach for access to service. The referral process can occur through multiple avenues, including self-referral as potential enrollees into FCS. Next slide, please. A February study published by the Research and Data Analysis Division reported some initial findings of the success of the program. The study found that persons enrolled in supportive employment services experienced improvements in employment rates, earnings, and hours worked. The study also found an increase in transitions out of homelessness and a reduction in emergency department usage by persons enrolled in supportive housing program. Next slide, please. The graph demonstrates the comparison for inpatient utilization of the emergency department for Medicaid beneficiaries with behavioral and physical healthcare relative to a matched comparison group. The red bars indicate 6 months prior to program entry, and the orange bars indicate 6 months after program entry. As you can see, the success of this program is an illustration of the strength and resilience of the population we serve. Thank you for your time.
Great, so I am thrilled we got through all 5 presenters. That's a lot to get in 1 hour, and thank you everyone for bearing with us and your attention, I'm sure, during that whole time. So Steve, I have been completely neglecting the chat, and so if you want to elevate maybe a couple questions that we can take before we wrap up.
Sure. So one of them it was the first question we received in the chat, and I don't know if we've really talked about it in detail, but Andrea from NYCHA was asking, when you're leveraging data, how do you include residents in that process? Like, are you bringing data to, resident engagement events, or, including that in your process? So I don't know who wants to take that question, but I think all of you could probably speak to that in different ways.
Sure. So, I mean, there's the usual routes via our councils. And so letting them know about our activities and some of the learnings and helping, I think, like, make sense of the data. And that was a piece I was getting at, is we really want to make this a more like broad and intentional effort beyond that group that we have. So we've thought about doing data walks of, and I think a big piece of it, so as Alistair mentioned, when we set out this project, it was going to be like creating a linked data set that we had access to. A big piece of it was democratizing the data and making it public facing. And so it's there's a dashboard that everyone has access to. But yeah, our intention is to move forward and bring this more thoughtfully out to the community, and to really get the community knowledge about what they're seeing and the disparities that we're seeing, to help us plan and to address some of those disparities. So that's the next step in this partnership.
Andy, anything from Vancouver?
We have, I didn't touch on it because we have so much else on the data, but we have our own sort of data effort going on called Community Connections. And we're right now sort of working with a partner on seeing how we can create sort of like an advisory council to sort of have real-time back and forth input from some of the folks that we're serving in sort of how we should interpret the data and use it.
Great. A couple quick follow-ups, Carlos, about your program. We got a question about like which partners you're working with and how that has been going, and then a question about during the pandemic, how have you been providing these services remotely?
Yes, so with partners we've been working with, there's other supportive employment providers as well within our community, which have already established some employment partners. And we work with agencies, especially with our supportive employment specialist, has connections with several employers in the community, which they formed the relationship with those employers, and we've been working in, but it's typically employers such as like Walmart's, Safeways, things like that, grocery. It's really dependent on what the individual wants to do for employment. Sometimes there's a temporary employment that's put in place if the individual works, but we've been working to build up our network of employers. For the most part, we work with like vocational rehab employers or partners, and we have a partnership with directly with our vocational rehab specialist partner here in Yakima.
Great.
And then you mentioned about the last question, the Family Self-Sufficiency Program. So everything is still continuing. We are doing remote calls. We are utilizing Zoom really to keep communication with our clients. We are doing everything by mail. So if there's plans that are being designed for like services, they're all being mailed still to clients for their review or emailed. And then we review them everything by phone. Referrals to resources. A lot of agencies here in our area are providing resources or services via phone. So those referrals are still continuing, and we just basically provide those additional contacts for those agencies. So we're continuing doing the same work. It's just all being done remotely. Our agency hasn't closed down. It's just been closed to the public, but we're continuing to be in our offices or work remotely. I
would encourage folks, we'll share out the link to the dashboard, or maybe that's available somewhere in the app, or we can post in the app so we can see it. And so I just encourage you to go take a look. And we are seeing differences. Our voucher holders, we've used our vouchers traditionally more in conjunction with the homeless service program. And so there's definitely markedly different health experiences for our voucher holders as compared to our public housing residents. Then we also break those out by voucher type. So you can see like some of the supportive housing vouchers and the differences in health. And then one thing I wanted to add to my previous response is that we're really elevating co-design as a value and a way of doing our work at KCHA. And so moving forward, new initiatives we've built out a co-design framework. So residents are involved and their voices are involved in designing that programming. So I think Austin Housing Authority, I'd call them out. They've been a really amazing leader in this space. So they're another housing authority to look to.
We did have just one thing, Katie, maybe you might want to comment on. John Kane from Boston Housing Authority was asking, you kind of touched on this, but wanted to give you the opportunity to expound a little bit. Any meaningful differences you all look at between public housing and voucher households? And similarly, are there any major differences between you and Seattle? I know the makeup of your residents is different, and the spacing out and concentration is a little bit different.
Yeah, I mean, I think the regional piece is really important as well. We see generally, I mean, public health in general has these amazing maps around health disparities as a whole for low-income communities, and we see just incredible disparities in South King County. And so another thing I'd add is that our focus around COVID has been really focused on communities that have been traditionally underserved and that we're seeing these largest disparities in. So that's a piece that I'd add. And then, yeah, just generally regionally, the geography is reflective in those differences. So we're a large, like kind of the suburban provider of King County, and then Seattle is more focused in the metro area. But yeah, we do see some differences. We saw in KCHA and SAJ too, but we saw a huge disparity with ED visits among Black women. And so avoidable ED visits in particular. So that was a piece that we pulled out from the data and are hoping to make more sense of that and to work with residents on how we can address that. Yeah, I think King County is, I mean, as they said in the plenary, people aren't maybe going to their website, but it's an awesome website with a lot of resources and a lot of democratized data showing these heat maps around health disparities. And I'm sure other health departments are doing the same work, so I just put a plug in for that.
Great. Well, I want to it's too bad I said in the last session, we don't get like thunderous applause at the end on Zoom, but I just wanted to give everybody on this panel kudos. We had a lot of presenters, but I thought it was all great information. And you guys were pros with Zoom, so thanks so much. Round of applause if you can applaud in like one of the settings here if you want to. Yeah, Katie just did the reaction at the bottom. So like Katie mentioned, we can also add things to the session on the app and agenda. So Katie, we can link to the dashboard and we can post any other resources you'd like. So for attendees of this session, consider that a repository. When the summit's over, we'll also have like a wrap up email that'll sort of lay out all the things that are included in that, that repository. So thanks again to the panel, and we will see you shortly.